Well, good afternoon, everyone. My name is Jamie Terrell. I lead marketing communications here at Saltmarsh, and we're happy to have you here with us today for part 2 of our webinar series on CARES Act provider relief funds for post-acute and long-term care providers. If you happen to miss our first webinar on this topic, that's all right. We've held one at this point and others on other topics weekly, really, since the onset of the pandemic. You can always find these along with other helpful information on our COVID resource hub. This is accessible at the top of any page on our website, and I've just also dropped a link in the chat if you want to check that out. There's a direct link there. You can visit saltmarshcpa.com/COVID-19. Joining us again today are 3 members of our healthcare consulting leadership team. We have Andrew Kent, Claudia Reingruber, and Al Grimes. We're glad to have them leading our presentation today. Before we get started, I do have a few quick housekeeping items to address. First, everyone on the line has been muted. If you have questions during the presentation, feel free to share them with us in the chat, and we'll hold them for our Q&A segment toward the end of the presentation. You're also welcome to share your questions with us directly by email, and someone from the team will follow up. We'll have our presenters' contact information available for you in the slides as well. Today's presentation is being recorded, and you'll receive a recap email from us tomorrow, including a copy of the slide deck and a presentation recording. In that same email, you'll see a link to complete a short survey. It should take less than just a minute, and we really do appreciate the feedback as a means to improve our live and virtual events. If you've enjoyed our webinars, please take a moment to let us know, and we'll keep them coming. With that, I will pass the mic over to Andrew Kent, shareholder and leader of our healthcare consulting practice, to get us started.
Thanks, Jamie. And hello, everybody. Thanks to all who have joined us on the internet this afternoon. I appreciate your time and attendance, and hope we get you some useful information today. So, as Jamie said, this topic of this webinar is CARES Act provider relief funds. We're going to talk about an overview of the various funds, some of the terms and conditions of the funds, how to track lost revenue and increased expenses related to COVID-19, and some updates on the reporting requirements, which have changed pretty significantly for providers here in the last few weeks. Joining me today, they'll get a chance to introduce themselves in just a few minutes, as Jamie said, are Claudia Reingruber and Al Grimes. So this slide is just a quick overview of our firm. Saltmarsh Cleveland & Gunn is a 75-plus-year-old firm, actually in our 76th year this year. Based primarily here in the Southeast, but serving clients all over the country, certainly in our healthcare practice. I think we're in about 20 or 25 states. So today's agenda, we have a lot to cover. We're going to try to move quickly. We may not get into detail on some of the items you may have questions about, so please, as Jamie said, feel free to ask us questions through the chat mechanism. If we don't get to the questions in the hour we have allotted today, we'll do our best to respond to everybody offline after the webinar. Primary topics today, though, are going to be an overview of the CARES Act COVID-19 relief funds, the general distribution funds and targeted distribution funds that probably most of our viewers today are familiar with, a very brief touch on some of the other relief programs, and then really the meat of today's focus is going to be a focus on the terms and conditions, the attestation requirements, the best practices on tracking how you use and apply those funds, what the reporting obligations are, and a focus on some of the most recent clarifications that we've received from HHS. We're going to do our best to keep all this in an hour, so we're going to move fairly quickly. The next slide. So once again, an overview of the CARES Act relief funds. There are several kind of buckets of funds here that you may hear about, you may have received funds for, you may be aware of. There's the Medicare Accelerated and Advanced Payment Program. There was a suspension of the Medicare 2% sequestration. There's various CARES Act SBA-backed loan programs, such as the Economic Injury Disaster Loan Program, the Payroll Protection Loan Program, and the Market Street Loan Program. We know many providers out there have taken advantage of one or more of these programs. Those aren't going to be a real focus of today's presentation, though. The next bullet here is where we're going to spend our time, which is the CARES Act Provider Relief Funds. These are the funds that are being administered by DHHS. They fall in a couple of different buckets, the general distribution and the targeted distributions. And to jump right into a more detailed explanation of those different buckets and the funds, I'm going to turn it over to Al Grimes. So Al.
Thanks, Andrew, and good afternoon, everyone. Just a quick aside, Andrew's previous slide there, where we're covering the CARES Act Provider Relief Funds in this presentation. As Jamie mentioned earlier, if you have questions or additional information on the PPP loan, we've had several webinars on that particular program, and those, I believe, are posted on our COVID-19 page, resources page. And the CARES Act Provider Relief Funds, there were $175 billion in total of funds that have been allocated to HHS for distribution. They've got a $50 billion segment designated for general distribution. This is to be allocated to providers who billed Medicare fee-for-service in 2019, and is to be based off a proportional share of their 2018 gross receipts. And then $125 billion in targeted distributions. That's more of a specific areas of providers who are particularly impacted by the COVID-19 outbreak. These funds are considered grants. They are not loans. They must be according to the HHS terms and conditions, and it's also in the frequently asked questions if you want to look it up on the website, on their website. They must be used to prevent, prepare for, and respond to coronavirus, which is a relatively wide net. And they cannot cover expenses or lost revenues reimbursed from other sources. The use of the funds are, like most government situations, subject to audit, and any non-compliance, once all of the guidances and all of the prescriptions have been released, will be grounds for recoupment. CMS has been instructed to, but has yet to release any guidance as to how we would, for Medicare Part A providers that file cost reports, we've yet to have instruction on how they're to be treated on those cost reports. If we could have the next slide. Thank you. This is a bubble slide that illustrates how the $175 billion worth of funds has been sliced and diced, if you would. In the gold circle, this represents the $50 billion in general distribution funds we just mentioned. And then in the light blue circles that you see there, this is the further segments of the targeted distributions going to provider areas that have been acknowledged that could be more heavily impacted by the COVID-19 crisis, such as rural providers. $10 billion has been assigned to that slice. We've got $12 billion for COVID-19 highly impacted areas. There's allocation for skilled nursing, Indian Health Services, safety net hospitals, and the Medicaid and CHIP programs. These are the targeted distributions to date. As is noted at the bottom of the slide, there is, I think it's 72, approximately, I can't hardly see it from here, billion yet to be distributed. Could we go to the next slide, please? This is just a further definition of how the funds are being allocated among the various general and targeted distributions. As a percentage representation of the total 175 billion, you can see that we still have approximately 41% that remains to be distributed by HHS. When you look at the targeted funds that were mentioned on the previous slide, the amounts such as 10 billion for rural, you can see that that represents, those rural providers represent 6% of the total of the 175 billion. For a numbers orientation, that's 4,000 rural providers that are being affected. They've also included for high impact hospitals, 395 high impact hospitals, 7% of the funds. Of the SNF amounts, of which many of our clients have spoken to us about, represent just 3% of the pie for 13,000 providers. And then even the Indian Health Services gets involved, it's less than 1%. But it represents 300 programs. So that's cast a wide net across various operating entities. If we could go on to the next slide, please.
Yeah, I'll just say one comment here is that, HHS has made it pretty clear that part of their process here has been to keep, to use an old phrase, their powder dry to a certain extent. So, they make numerous references to potential further allocations of funds, and I think it's pretty clear that HHS here is kind of sitting on some of the money as they watch and see how the current pandemic evolves. And, so they have the ability to respond to later events.
And to further that, then, wouldn't you say, Andrew, that it doesn't necessarily mean that new targeted distributions, in other words, new providers, it could be that they allocate additional funds to existing targeted distributions.
I think
they have that ability.
I think that's absolutely a possibility.
So with the this particular slide is giving us a slight breakdown of the $50 billion was actually distributed in two, what's referred to as tranches. The first tranche of 30 billion was payments were made between April 10th and April 17th. And these were distributed based upon your 2019 Medicare fee-for-service billings. The second tranche, the $20 billion, is going towards approximately 15,000 or so providers that these were, this second tranche is in essence being used to true up the total payments made of the entire 50 billion based upon the provider's 2018 net patient revenues. Of this $20 billion tranche, there's also funds available that can be distributed based upon portal application of revenue submissions that have come through, and there's been 2.4 billion of those through June 15th. And as it's noted here on this slide, there actually has been potentially a third tranche to distribute any funds that were not claimed or were returned by providers from the first and second tranches. We could go to the next slide, please.
Okay.
This slide, in essence, is a timeline of the targeted distributions that have taken place beginning in May. And these should be somewhat familiar from the previous slides. 10 billion were paid to the rural providers on May 6th. There's 12 billion paid on May 7th to the high impact hospitals. We had beginning on May 22nd, 4.9 billion was sent out to 13,000 SNFs. There was an additional an amount that has been noted and is more recent of 15 billion is to go to Medicaid only and CHIP providers. Now, to note with regard to this particular allocation, these, if you receive money, if a provider receives fund in the general distribution, you're not considered eligible for an allocation or a payment from the Medicaid only CHIP distribution. However, if you received a payment from another targeted distribution, that does not preclude you from receiving money in the Medicaid only distribution. And the same frequently asked question dated 6/9 also noted about $10 billion that's going to be going out to safety net hospitals. And with that, I'd like to turn it on over to Claudia to begin the next series of slides.
So, so Al, Claudia, just a quick point on that, because I know this is something that the three of us have received a number of questions on those frequently asked, on that frequently asked question about the Medicaid distribution. You know, we have a number of providers, a number of clients who've reached out to us that have a Medicaid only subsidiary inside their organization. And they were asking, you know, can that subsidiary apply for the Medicaid only funds if the parent company has received funds through the $50 billion general distribution fund? And the answer in general is no. If the parent organization or the tax filing TIN has received a payment through the general distribution portal or that general distribution fund, then their subsidiaries aren't eligible for the Medicaid only fund. It's really those providers who did not receive a prior payment at all through the general distribution portal and our general distribution fund, and who that the Medicaid only piece applies to. So Claudia, I think I've got a slide or two here on some more terms and conditions, and then I think you've got a little deeper dive for us here in just a second. So this is just a quick overview of the terms and conditions. So providers must attest to the terms and conditions within 90 days of receiving funds. If you don't attest and retain funds, you'll be deemed to have attested. If you've been in dealing with this for the last several months, you know that deadline has moved numerous times. So it was originally 30 days and then 45 days, and it's currently 90 days for attestation. There was also a June 3rd deadline for uploading revenue information. That deadline has passed. That was to determine additional eligibility for the second tranche from the general distribution fund. Other basic high-level terms and conditions that kind of in blanket apply to all of these different funds, both the general distribution fund and the targeted funds. The funds have to be used to prepare for and treat actual or possible cases of COVID-19. We're going to talk about that in a little more detail in another couple slides. They're also to replace lost revenue associated with COVID-19, and this is another key element we're going to spend some time on here in just a minute. The terms and conditions generally contain some limitations on balance billing. They contain reporting requirements back to HHS, and as you see in this frequently asked questions, kind of covering something that we get a question on is, you know, how long are you going to be subject to these terms and conditions if you accept the money? And so generally, you know, the general guidance is the HHS hasn't put a timeline on the use of these funds. They expect the funds to be used for coronavirus response and to replace lost revenue. And they expect, you know, that will continue as long as you're continuing to use those funds in that way. Once you've exhausted the funds, then, you know, then you're essentially, your requirements start to end. Though they do, HHS has stated they expect providers to maintain records for at least 3 years from the date of final expenditure. So you accept the funds, you're in the program for at least, you know, what's probably a 3 to 4 year timeline at minimum. These are just some sample terms for the general distributions. And once again, these kind of apply across the board. But for the general distributions, you know, you must have billed Medicare to be eligible. As we've already discussed, you have to provide testing, diagnosis, or care to individuals with possible or actual cases of COVID. You can't have been terminated from the Medicare program at any time. You have to attest that the payment's only going to be used to prevent, prepare for, and respond to coronavirus. So, these are some of the kind of basic terms and conditions that all providers are expected to meet. And with that, we're going to jump into a good bit more detail on some of these terms and conditions, and specifically the proper use of funds and how to calculate your lost revenue. And with that, I'm going to turn it over to Claudia Reingruber. Claudia?
Hi, good afternoon. So I'm going to be talking about the attestations that you have to make if you're a recipient of some of these funds. And it's important to note that there's a separate attestation that is required for each fund payment that you receive. So for example, if you received, you probably received as a Medicare provider, you would have received a payment from the tranche 1 from the general distribution, and that had its own terms and conditions. And there was also a second tranche, and that had its own separate terms and conditions. So each one of these distributions that have occurred to date has their own terms and conditions. Although they're very similar, it would be important to read through them each time you sign them to make sure that you understand what your obligations are as a recipient of these funds. Andrew also mentioned that the deadline has been changed, and many of you, I'm sure, are very thankful for this. So now that our attestations are due within 90 days of receiving the funds, so that gives you a little bit more flexibility. Initially, the deadline was 30 days, as Andrew said, and then on May 7th, they changed it to 45 days, and then May 22nd, they changed it to 90 days. I doubt they'll change it again, but so 90 days is probably what you're going to have to live with. But is just one small indication of how many times these rules have been modified or clarified as this whole CARES Fund process has proceeded. Each attestation is going to require that you confirm the amount of the payment that you received in that particular distribution. You have to identify the bank account into which it went, and you have to also then certify your agreement with those specific terms and conditions that apply to the payment that you received. Included in that is most of the pages in the terms and conditions are associated with general requirements related to any kind of governmental grant. So you'll notice that there's a lot of things that are precluded. You can't spend the money on lobbying. You can't spend the money on a whole variety of things. But the first few pages are the ones that are unique and kind of specific to these CARES funds distributions. And the attestations are made online through a governmental portal. And we've given you the link here to this portal. And that's where you would go to make the attestations. So at this particular point, just to illustrate how many different, Al went over this, but to illustrate how many different distributions have been made, we've had 2 general distributions, and then we've had probably 9, close to 9, separate other targeted fund distributions with some remaining. So I think it's important, even though you are not getting all of those other distributions, to keep in mind where this money is going, because it is taxpayer dollars, and so that if you are encouraged by the trade associations that you're a member of to be an advocate for additional distributions, if you feel like it's probably good to understand where all of this money went and what money remains. Certainly, I think they're doing their very best to try to target those funds to places and providers that have been the most impacted by the COVID-19 pandemic. And if we can go to the next slide, we want to clarify some terms that we get a lot of questions about. What is the difference between a possible case of COVID-19 or a presumptive case of COVID-19 versus an actual case of COVID-19? And what are the implications of each of those terms? And I think this is something that is really has been clarified in the frequently asked questions. The most recent version of that was published on June 22nd. So you may want to take a look at and monitor that website, or we will try to provide updates on information as those are changed significantly. But when you're looking at a possible case of COVID-19, HHS has stated right from the very beginning that they broadly view every patient as a possible case of COVID-19. And this is in recognition of many factors. We know we have asymptomatic transmission. We know that not everyone's been tested. So it's not only, there's no way to really be able to determine whether or not you're dealing with a case of COVID-19. Transmission is possible when a patient is asymptomatic. Transmission is possible before a patient when a patient is infected with COVID-19 but is not yet demonstrating any symptoms and may not be aware of it. And then as well as when someone has COVID-19 but the symptoms might be mild and they may not be aware of it. So every patient in your building, in your nursing home, every patient in your home health agency, every patient you're treating can be viewed as a possible case of COVID-19. A presumptive case of COVID-19 is used specifically in connection with the prohibition against balance billing. And we're going to talk about that on the next slide. But it does not, you do not have to have a presumptive or actual case of COVID-19 in order to be able to use these CARES relief provider funds. So presumptive case of COVID-19 would be someone where you've documented in the medical record that they have symptoms that likely could support a case of COVID-19. However, you don't have a test that demonstrates that they do in fact have COVID-19. And they use this terminology of an in vitro diagnostic test. And for lay people like me, that simply means that they took a swab of material or fluid from the body of the patient you're testing, and they tested it in a test tube or in a laboratory dish or away from the patient. That specimen is tested and the results are returned. So presumptive case means someone where they are exhibiting symptoms that you believe may be COVID-19 related, but you don't have an actual diagnostic test that supports that, an actual case of COVID-19. And of course, an actual case of COVID-19 is where you have someone who's had an in vitro diagnostic test, and it has confirmed that they do indeed have COVID-19. So those are the different terms that are used in the frequently asked questions and the terms and conditions. And it's really important, I think, to understand the difference between those three.
Yeah, Claudia, and I'll just highlight, like you said, this is something that we've gotten numerous questions about because HHS's use of the terms possible and presumptive has been very confusing, I think, for a lot of providers. But essentially, like you said, the possible cases that really affects your eligibility and how you can use the funds. And so as long as you're using the funds for healthcare, patient care in your facility, you're treating what they consider a possible case of COVID-19. And so I know you're going to talk about the balance billing issue here in a little bit more detail. So we'll go on to the next slide.
Okay. So let's talk about a presumptive case of COVID-19. And the term presumptive really comes into play when you're talking about how you bill for the services that you furnish. The government has recognized, and HHS recognized that that there are going to be a number of patients as a result of the public health emergency who may have a certain health care plan that requires they use designated providers to receive treatment. And HHS realizes that many providers have capacity limitations, so that it's possible a patient with COVID-19 will not be able to access treatment or care through their usual provider network and may have to go outside of network. And in that particular case, if a patient comes to your facility and you are not an in-network provider, then the patient can come to you and receive treatment, and you will be paid at the in-network price, but you will also be limited in collecting from that patient. You'll be limited to the amount of co-payments or deductibles that are that would have been the patient's obligation if they went to an in-network provider. So that simply says that you can't balance bill. If you treat a patient who is out of network, then you have to only charge them for the out-of-pocket costs that they would have been charged if they've been able to go to an in-network provider. And that's the important distinction. That's really the significance of the terminology of a presumptive case and an actual case. So when you're treating those types of patients, a presumptive or an actual case, your terms and conditions restrict your ability to balance bill or to bill more than what their out-of-pocket costs would have been if they were able to stay in network.
And Claudia, I think isn't this whole provision kind of designed to deal, help both patients and providers, give some clarity in situations where there's an expectation that there's a lack of availability of beds if you start to have providers reach capacity, and so you're having to move people out of network and that sort of thing. A lot of our clients haven't experienced that because really a lot of that's only happened in the Northeast so far, but with case numbers creeping up, this may be something that at some point many of our clients and many providers here in the Southeast may face at some point.
And I think that's a really good point, and I think it's also important that your billing staff know this, because normally they might avoid taking a patient who's out of network because they may not be able to get paid or get paid an appropriate amount. In this instance, you are going to be able to get paid for taking an out-of-network provider, and the terms and conditions require that you recognize you can't charge them more than what they would have paid had they been able to go to an in-network provider. So these terms can be very, very confusing, and we hope that this helps clarify some of the differences between those three terms.
When we were discussing that particular slide, I think one of the consensus we came to is that bottom line, the programs, the government's viewpoint is everyone's in network.
Yeah. For treatment of COVID. Mm-hmm.
Yes.
So uses of funds. This is another clarification that HHS added on June 19th. And it talks about healthcare. How can you use these funds? And it makes clear that you can use these funds for healthcare related expenses attributable to coronavirus. And admittedly, that's a very broad term, and it can, as the FAQ states here, it can cover a broad range, and they recognize that there's a wide range of items and services that can be considered healthcare related expenses attributable to COVID. They also state that that these items and services that you purchase are going to be used to prevent, prepare for, and respond to coronavirus. And so, you're preparing for COVID-19. Not only you've been preparing for COVID-19, you're probably tired of preparing for COVID-19, but the good news is that those expenses that you've been incurring, even if you don't have a case of COVID, those expenses can be used, can be covered through the use of these provider relief funds. So these expenses incurred to prevent, prepare for, and respond to the coronavirus. And here's some examples that were included in the frequently asked questions in an effort to try to illustrate how broad the terminology here is. You've incurred expenses for supplies used to provide healthcare services for these patients that you're taking care of who are all possible cases of COVID-19, and you may have some actual cases of COVID-19. You've incurred undoubtedly equipment expense to provide healthcare services for possible or active COVID-19 patients. Workforce training. I'm sure that this has been a huge focus area with all of the changes in our operational practice and the focus on the infection prevention and control. There's a lot of training and education that's had to be done with your staff and had to be done on an ongoing basis, and those expenses can also be covered by the COVID proceeds. And developing and staffing emergency operations centers, particularly areas that are in the a high impact area, such as New York or New Jersey, or in some of the states that are now looking like they're heading into that kind of territory, where infections are increasing, and there are several states, including Florida, where that's occurring. Reporting COVID-19 test results to federal, state, and local governments. And then beyond that, you have a reporting obligation for skilled nursing facilities, for example, to report when your staff or your residents have positive COVID-19 test results, et cetera. So there's a number and a variety of reporting obligations, both at the state, federal, and local level. And you may have built or be constructing temporary structures to expand your capacity for COVID-19, or to reconfigure the use of your space to accommodate COVID-19 patients in an area where they can be isolated and cared for separately. And you may be acquiring additional resources, all sorts of expenses, such as staffing and recruiting, and maybe contract labor, undoubtedly some technology expenditures, all of this in an effort to continue to be able to provide care to your current and future resident population.
Claudia, this would include things like, I know we've had clients who, for example, brought on third-party consultants to review their infection control policies. They've done, I mean, there's those types of third-party or consulting services that you might need to meet those
Right.
requirements would certainly qualify.
Right, and there's, I think we have some additional examples also coming up, but certainly, this is, as everybody has said, this is an event that none of us, even those of us that have participated in the program for 30 years or more, this is something that we've not seen before. So it has affected every aspect of our operations in whatever healthcare setting you're in, and it may take some thinking to really be able to track all of those expenses that you've incurred. And if we can go on to the next slide. I want to take just a minute and talk about the lost revenue aspect of how these COVID-19 relief payments can be spent. These can be spent, the provider relief fund payments can be used to prepare for, and respond to coronavirus, and reimburse for healthcare related expenses or lost revenues attributable to coronavirus. And lost revenues can be a very confusing terms, especially for lay people who don't who don't have a degree in accounting, who aren't a CPA, who don't deal with financial statements all the time. So, for example, lost revenues is the top line. In other words, what revenues have you lost from various payers, such as Medicare or Medicaid or private insurance or private pay? This is not talking about lost profits, which we think of, which is the bottom line. It's not. We're talking about lost revenues. What revenues have you been unable? You are no longer billing because of the impact of COVID-19 on your facility operations and your residents and the patients you're caring for, et cetera. So when looking at how you document this and how you spend these funds, it's important that any provider or recipients carefully analyze their expenses that they've incurred and the revenue that they've lost due to the coronavirus. And one other comment here is that it's more likely, based on the conversations we've had with providers, it's our belief that, our opinion, that understatement of these amounts is probably the greater risk than overstating, that there are probably more expenses that you may not be thinking of, or that just may not have been documented, or may not be considered when you're trying to determine how to spend these funds. And there may be revenues that you have lost that have not really been captured or thought about. So particularly with the lost revenues, you want to really think about what you would have collected, what you expect you would have collected had COVID-19 not occurred, and that would be from any of the payers that you deal with. The terms and conditions state in all of the terms and conditions for the various funds that have been distributed state that a recipient certifies it provides, meaning it provides now, or that it provided after January 31st, 2020, care for possible or actual cases of COVID-19, or preparing for or preventing having any COVID-19 cases in your facility. And you can go on to the next slide. So expenses, these COVID-19 expenses and lost revenues, be sure to capture any expenses that go back to January 1st of 2020. CMS or HHS has said that they expect it would be highly unusual for providers to have expenses prior to January, but it is possible, although they expect it to be unusual, and you want to have good documentation to support that. And then we've given you some other examples. Andrew mentioned the additional pay that you may be paying to your personnel. Increased hours by salaried staff is another thing to consider. All of the new processes and procedures, everything that's been associated with infection prevention and control, your new infection prevention, I can't say that word, preventionist, that you've had to designate in your facilities, et cetera. So there's a lot that, and don't forget your billing staff, because your billing staff and your clinical staff have had to deal with these 1135 waivers and what constitutes an appropriate application of the blanket waivers, and how do you apply those in your facility. So it really affects everyone in your particular facility. And with that, Andrew, I think this goes back to you.
Sure. No, thanks, Claudia. And I'll just point out, I want to go back to that first bullet, because I think this is something that I know we've had clients ask about, is this date issue, because there are several trigger dates in here and it can get somewhat confusing. In other words, to be eligible, you have to have treated, prevented, treated after January 31st. But when it comes to using expenses or quantifying the expenses that you're using to document forgiveness, as Claudia pointed out here, HHS has basically said there is no date restriction on that. They can be any expenses as long as they're COVID-19 related. Now, they have stated, as Claudia, I think as your slide points out here, that anything prior to 1/1/2020, they're going to have particular scrutiny on. Mm-hmm. But, when you're looking at these additional costs, you may have costs going back into February when this first started becoming, an issue, and you want to make sure you capture those. So on to estimating lost revenue. So estimating lost revenue attributed to coronavirus, as Claudia mentioned earlier, this is something where we've seen a lot of clients, a lot of providers by definition want to be conservative here. They're concerned about, they want to be concerned about overstating this. But as a result, we think a lot of providers are setting themselves up for a situation where you're not fully capturing the real impact here. So, there are a lot of factors in the current environment that could be contributing to lost revenue, especially across providers, fewer admissions, faster discharges or more discharges, reduced occupancy, reduced outpatient procedures in the acute care setting, patient and clients' unwillingness to go in, whether it's for a physician visit, whether it's an ER visit, or whether it's sending a loved one or admitting a loved one into skilled nursing. A lot of people are just holding off on making those decisions right now because they're concerned, if mom or dad goes into skilled nursing, I'm not going to be able to go visit them because of the visitation restrictions. And they don't want to do that. Or if you're making a decision about going to see your, your physical therapist, well, maybe I don't want to go in right now because I'm concerned about infection. So there can be lots of things driving a drop in revenue. Um, Certainly, the methods, and once again, what we want to reinforce here is that the methods of estimating lost revenue should be tailored to your unique circumstances. So the guidance from HHS is fairly open-ended and basically allows any reasonable methodology for calculating your lost revenue. It gives an example of a year-over-year comparison or a budget to actual comparison, but we want to, we would encourage providers to make sure you've looked at other possible methodologies, including analyzing your trends pre-COVID, making sure you're capturing any growth or changes. A lot of our clients in the post-acute and long-term care side have, went through the rug for the PDPM conversion late last year, and you may have changed your method of operations, or you may have tweaked your processes, how you're admitting patients, the type of patients you're admitting, and you may, we have a number of clients and seen a number of providers who've actually experienced increases in their per diem reimbursement rates. And so, make sure you capture that. These are things that wouldn't normally be captured if you simply compared March and April of 2020 to March and April of 2019. So just to kind of highlight this, we just came up with a very simple test case. You could spend lots and lots of time. I've spent a better part of my career for the last 10 years talking about issues around lost revenue, but this is just a simple, kind of exhibition of how this could impact these calculations. So we have our little hypothetical here, Shady Acres Skilled Nursing Facility. It's a 100-bed SNF. In March and April of 2019, their average daily rate was $300 across all providers, and their occupancy was at 92%. You don't have to remember these numbers. There's not going to be a test. We're just kind of setting the background here for a little illustration.
Hypothetical, right? Hypothetical.
That's just a hypothetical. And for 2020, this Shady Acres had budgeted an average daily rate of $325 with occupancy remaining consistent at 92%. So a slight increase in their average daily rate, occupancy was going to stay the same. That's what they had budgeted pre-COVID. 2020 actuals, the average daily rate's down to $250 and occupancy's down to 85%. That's something a lot of providers we know are experiencing. You've lost maybe your Med A patient base, so your census is down. Not only is your census down, but when you lose those Medicare patients, your average daily rate starts to come down, move back towards maybe your Medicaid rate. And so that's what's happening right now. But prior to COVID, they were actually ahead of budget. They're for the 3 months ending February 28, 2020, maybe their average daily rate was up around 340 and occupancy was running a little bit ahead at 94%. So given that basic scenario, how would Shady Acres estimate its lost revenue? And this is really what we're wanting to highlight here. If you take those numbers on the previous slide and you compare 2020 actual for March and April to 2019 actual, you come up with $385,000. If you compare 2020 actual to 2020 budget, it's $527,000. And if you take that pre-COVID trend and extrapolate it forward and compare it to 2020 actual, you're at $653,000. So the use of a pre-COVID trend as compared to 2019 actuals made a $267,000 difference, almost a 70% difference. And this is crucial. We get that for most providers, you've already had to log in and upload your March and April revenue, but we are expecting a continuing requirement to report lost revenue. And so as you look at documenting, your lost revenue going forward, we want to encourage all our providers out there to just, make sure you look at where you were, what your reasonable expectations were pre-COVID and what you were actually doing pre-COVID, rather than just going back and doing a straight year-over-year comparison, because documenting and supporting these lost revenues, we think for a lot of providers, is going to be the way they document the use of the majority of these funds. And so, we're certainly not, we want we want you to be, we're just encouraging our clients to be as accurate and thoughtful and as detailed as possible here, because you want to make sure you capture everything. If you don't capture everything, you could very easily find yourself in a position at some point down the road where there's where you're having to give some funds back. So in the last couple minutes here, we've got about 10 more minutes left. Oh yeah, go ahead, Claudia.
I know we're running out of time, but just a couple of quick points. One is that this kind of situation, this kind of difference is not necessarily at all atypical.
No.
For example, a lot of providers have found that they did better or were doing better under PDPM than they were doing under RUG 4, and that would have been a very relatively recent trend, accounting for the fact that you'd have to adjust your operations, and by the time you were probably getting to where you felt really comfortable about what you were doing under PDPM, then we get hit with COVID. So looking at the most recent months is very critical and can make a huge difference in this lost revenue estimate. Secondly, is that write down the assumptions that you're using. Why do you think the first two methods, just for example, that we've used in the slide, why do you think those two methods were not appropriate, and why is the methodology that you're using better? What does it reflect? And it may be something like the conversion from RUGs to PDPM, and how you've operationalized that, and how you've been successful in working with your local hospitals, et cetera, to improve your revenue. So document your assumptions, because 3 years from now, you might forget what it was that you used to develop those lost revenue estimates.
Excellent. Good points, Claudia. All right, we're gonna ask Al to address very quickly then some kind of best practices on the accounting side, and then Claudia's going to address some reporting requirements before we open it up for questions. Al?
Thank you. I'm really just going to, quite frankly, wave my hand over this slide, because most of the providers that are on this call, especially since this deep into the situation, are performing tracking the expenses that you're having to expend for the COVID-19 emergency. So you've probably already got many providers that we've talked to are using Excel spreadsheet. Some are using their general ledger accounting system. We do recommend that you do have on your general ledger, at a minimum, you're going to have all these expenses as part of your normal monthly accounting system, but have separate general ledger cash accounts to record the proceeds from your CARES relief funds, also segregate your PPP funding, etc. Deferred income account for your funds, and until you actually have used them and applied them, and then tracking the increased expenses. There are, again, you can use your actual payroll system instead of specific codes for time that's being spent, say for overtime that's necessary. Housekeeping has to do deep cleaning on a periodic basis that you would normally not have had in the normal course of business. Infection control procedures that you've had to, and Claudia mentioned in an earlier slide, that were mandated by CDC and CMS, the costs associated with implementing those. So on your payroll, if you have employees and you've actually experienced staff that have come down with COVID-19 or have to have the 14-day quarantine, etc., carve out an employee's sick leave from other pay that they would have received. So that's really, we're always happy to discuss your current system if you have questions on it, if you feel like it needs tweaking, or you just want, because at the moment there has been no guidance, specific guidance with the type of documentation. That potential for the reporting requirements is still outstanding. We're waiting on it also. So the worst thing you can do is do nothing. So anything else you're doing is good as what everybody else is doing. So if we could move on to the next one.
Yeah, and I'll just point out real quick, Al, those are great points, and just, also point out that now is the time to be doing this. So if you haven't implemented some of these, whether if you don't have an Excel spreadsheet yet, or you're not using your existing accounting system and have set up new GL accounts, go and do it now. Don't wait 3 months or 6 months or a year down the road.
Especially given the fact that that we've had some extensions.
Yeah.
Where they've extended the time from the 45 days to the 90 days. And it would be natural with providers, while they're combating the actual clinical side of this, to potentially push off to the side, thinking it doesn't have quite as much urgency, and actually it does.
Yeah, one area, and I'll just point out one other area that we've seen a lot of challenges for whether it's providers or just businesses in general, is document that salaried time too. If you've got salaried individuals who are having, for example, we've had clients who've had their accounting team doing, working with dietary, doing room service because they couldn't get enough dietary folks in. If you've got salaried people who are doing those frontline type healthcare providing because you don't have the staff, make sure you're documenting where those hours are going, because you can allocate those costs, and those might not otherwise be captured if you just ran a payroll report for your dietary staff. So Claudia's going to talk a little bit about the reporting requirements, and then we're going to open it up for some questions. So Claudia?
All right, and this is a very happy slide. I hope everyone will appreciate this information, because the reporting requirement that we were all expecting, all providers were expecting to have to comply with by July 10th, has been eliminated. So quarterly reporting does not have to be done by the individual recipients of the CARES relief funds. HHS is going to be handling that in a way that complies with the CARES Act requirements. So they added this as a frequently asked questions on June 13th. So that's the good news. There is no quarterly report required on July 10th. Having said that, though, there is a future likelihood, not even just a likelihood. If you look at what this language says on the slides, it says HHS will develop a report containing all information necessary for recipients to comply with this, and that HHS in the future will require providers to submit information on request. The FAQ added on June 13th said HHS will notify recipients of the content and due dates of such reports in the coming weeks. We don't know what in the coming weeks meant, but it does mean that, just to highlight what Andrew and Al said previously, is you don't want to put this accounting mechanism off and figure you'll catch up with that later, because you are going to need to be able to comply with whatever reporting requirements the secretary comes up in the future. And that we know that the reports will contain, among other information, the total funds you received, the amount of funds you used for each project or activity, and they also want to know the estimated number of jobs created or retained by the projects and activities that you've undertaken. And reports shall be in such form with such content as specified by the Secretary in future program instructions. And with that, we've also included a key reference slide. There are probably lots more key references, but the things that we thought you'd be most interested in is where do you go for general information for providers? Where do you go for general information such as the timeline of when these funds were released and related to a variety of other things that are included in the general information. Frequently asked questions, which are updated sometimes 2 and 3 times a week, and have expanded to 42 pages at present. There is also a separate frequently asked questions document for billing questions, which is currently at 128 pages. So if you haven't seen that, you might want to keep your eye, that's something your billing department and your financial people would probably be interested in. So with that.
Excellent. So Jamie, I know we've got Al and Claudia, thank you both very much. And thanks for everybody who stuck with us for the last 59 minutes or so. Jamie, we may have a minute or two I know we want to end on time, but we may have a minute or two for questions. Do we have any questions?
Yes, we got a couple in the chats. We had Monty Reed ask pretty early on, will the Fed give us instruction on how to send back any unused stimulus this year so we don't have to pay tax on it? Do you guys have any guidance there?
So I think the guidance there right now is that they have noted that at some point, if the providers do not use all of their funds, that HHS will seek recoupment. Exactly how and the methodology for seeking recoupment, we don't have guidance on yet.
Perfect. This may have been on an earlier slide, but do we know how much hospices have received as a ratio compared to hospitals? Do you guys have that information?
Claudia, now I don't think the data is broken out at that level. I
don't think they sliced it that deep, have they?
No, but they have released information as to who has received money. And some of that may, so individual providers and many hospice providers are probably, separate providers have their own tax identification number. There is and one of the links that we provided on the previous slide will give you, will take you to a data slide. And there is a listing by state of every provider or tax identification number that received funds. And these are funds that have been attested to and accepted and are listed by state, and you can sort and analyze this in any which way you'd like. So that may be one way to obtain the information you like, as well as looking at your trade associations to see if they've been able to dissect that for you.
Jamie, do we have time for maybe one more?
Yeah, we've got one more. What about lost revenues when the building is a CCRC? They went further to clarify, which includes AL and IL. You all may know what that means.
Yes, that's a great question. Not Al, no. CCRCs often will have various levels of care within their campus. So they'll have skilled nursing. They may have home health agencies, Medicare certified, private duty. They may have they're going to have a skilled nursing facility, AL or assisted living. And then they may have independent living. And all of those revenues, if they're reported under a tax identification number for the CCRC, which is most likely, then all of those revenues can be included when you're looking at lost revenues. If you're within a campus like that, you certainly had to take additional steps to protect your assisted living residents, your independent living residents, et cetera. And so there is a Q&A that clarifies, and we can give you the specifics on that, but it's in the 622 frequently asked questions that makes it clear that all of those revenues can be included. Now, if you have a real estate company or something along those lines that's unrelated to healthcare, those would have to be excluded, but certainly all of the areas that you mentioned could be included when you're doing the lost revenue calculation.
Yeah, and I'll just add that the frequently asked questions also, state that providers have a substantial amount of discretion in order to allocate funds among their various business units or subsidiaries as they want. So you may have received funds based primarily on a calculation for your skilled nursing facility, for example. But as long as the funds are being used properly, you have the ability to allocate them among your different business units. And I think with that, guys, for our audience out there, if you have any other questions that you've submitted, we will we know where the questions are coming from, and we know who sent them to us. So we will try to reach out to everybody on an individual basis. But Jamie, I'll turn it over to you to close us out.
Sure. So as I mentioned, we'll follow up with all of the materials from today's presentation. You'll get those tomorrow via email. If you don't happen to receive them, we know that sometimes things get lost in the interwebs. So just know that we'll have this also loaded on our COVID-19 resource hub. You can find that information at saltmarshcpa.com/COVID-19. There's information on our past webinars, upcoming webinars, and lots of other information. So you'll want to check that out. You can sign up for email updates. And we've also got a webinar coming up next week. I believe we've got some information for you here. Yes, next Tuesday. We've got our part 4 in our PPP series coming up. So if you enjoyed what you heard today and you want to hear some more on PPP, please join us next Tuesday. It'll be a short week, but we'll have an hour packed full of the latest on that funding. So please check that out at our website. You'll see the link there on that slide. And I think that wraps us up for today. Otherwise, we appreciate you all joining us. Sorry we went a few minutes over. Please feel free to share any questions you have that did not get addressed with us, and we'd be happy to get those answered for you. So thanks again to our speakers, and we hope you all have a great day.
Thanks everybody for coming. And as Jamie said, we're going to leave the teams open for just another couple minutes. So if you have a question, please feel free to upload it. But otherwise, thanks for coming and spending a little over an hour with us on this Thursday afternoon. We appreciate it. Hope you found it useful. Thanks.